Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everyone, and welcome to episode number 174 of the Better Health Guy blogcast series. Today's guest is Dr. Nancy O'Hara, and the topic of the show is Demystifying PANS and PANDAS. Dr. Nancy O'Hara is a board-certified pediatrician. Prior to her medical career, Dr. O'Hara taught children with autism. She graduated with highest honors from Bryn Mawr College and as a member of the Alpha Omega Alpha Honor Society from the University of Pennsylvania School of Medicine. She earned a master's degree in public health from the University of Pittsburgh. After residency, chief residency, and general pediatric fellowship at the University of Pittsburgh, Dr. O'Hara entered general private practice in 1993, and in 1999 began her consultative integrative practice solely for children with special needs. Since 1999, she's dedicated her functional medicine practice to the integrative and holistic care of children with chronic illness and neurodevelopmental disorders such as ADHD, PANDAS, PANS, OCD, Lyme, and autism spectrum disorder. She is a leader in the training of clinicians both in the United States and abroad. Dr. O'Hara has written a comprehensive guidebook, Demystifying PANS and PANDAS, a functional medicine desktop reference on basal ganglia encephalitis, which is available on Amazon. And now my interview with Dr. Nancy O'Hara. I am very excited today to have Dr. Nancy O'Hara with us to talk about demystifying PANS and PANDAS. One of our listeners said, she has been healing my daughter and now my son. She's amazing in every way. So thanks for being here with us today. Amazing, Dr. O'Hara.
Thanks so much for inviting me, Scott. I'm thrilled to be here.
What was the personal journey that brought you to working with children with PANS and PANDAS and other neurodevelopmental conditions? What drives your very obvious passion for the work you do today?
You know, my mentor, Dr. Sidney Baker, always said, if you listen, they will come. And I have learned more from the families and the patients and the parents in front of me than anything else. And my journey is a little bit bifold, but always starts and ends with my own son. You know, I was at first a teacher of children with autism, and I mean this very seriously. I was a lousy teacher. So instead, I took the easier road and went to medical school. And I was a regular pediatrician in a practice and seeing a lot of children with autism because I had a proclivity toward that. And it was one of those kids who got better with diet. And that mom I actually knew from my hometown in West Virginia. And she came back to me and she said, you have to learn about this. You have to go meet this guy. And it was Sid, it was Dr. Baker. And at the time, I had been going through 4 years of infertility and Western medicine was really failing me. And I thought, well, diet doesn't affect behavior, but, maybe it'll help me. I'll go see him as a patient. And that changed my life. And that was when I first started to learn about natural and functional medicine. And I got pregnant several months after seeing Sid. It was amazing. And then almost 11 years later, my own son devolved into seizure-like tics and got bit by a Lyme positive tick and had a viral infection all in the same week. And thankfully, at that time, I knew enough that I threw the kitchen sink at him. And I've learned a lot since then. That was now 14 years ago. And I continue to evolve in my learning, adding more and more about Lyme and mold and everything else. But it all starts with the one child in front of us.
How have the types and severities of illnesses that you've seen over the past 20 years changed? In the book, you mentioned NOAA. That was one of the cases where stopping gluten and dairy really did move the needle. Does that move the needle today like it did 20 years ago? Are children becoming more chronically ill? And if so, What do you attribute to the increase in severity and prevalence of childhood illness?
Great questions. I think first, with regard to gluten and dairy, it still works. But the problem is that we have gluten sources that are not well identified in so many of our foods now, genetically modified foods, processed foods, and people aren't seeing that as a gluten containing product. And so I think, if you haven't seen gluten and dairy free work in your child with autism, for example, go back. You may have gone through a window and not through the door. And you need to reevaluate. You need to be 100%. It doesn't work if it's 99.9%. And myself, I have celiac. So I know once my stepson served me rice and I said, "Are you sure this is just rice? It looks different." And he goes, yeah, it's just rice. I was sick as a dog. And it was rice. It said gluten-free, but it wasn't certified gluten-free. And it had natural flavors. And natural flavors for people that are sensitive. So I think that's the gluten casein answer. It can still be very helpful. But I do think, back when Defeat Autism Now was around and I first learned from Sid about 30 years ago, we were a little bit on a whale watch, meaning, oh, the cure is over here. The problem is over here. No, let's go to this side of the boat. And it's never or almost never just one thing. And I think our environment and all of the things that we have been exposed to have only continued to get worse. And when we've taken, for instance, mercury out of vaccines, we've replaced that with aluminum. When we've taken some chemicals out of some products, we've put even worse chemicals in. We've got mold damage, we've got Lyme, we've got all of these things that are part of who they are. And our kids with autism are just our canaries. I grew up in West Virginia and we sent canaries into the coal mines. If the canaries died, it meant it was too toxic for the miners. Well, that's what the kids with autism are showing us. And then the kids with PANS and PANDAS are another sort of, in the Venn diagram, overlapping circle to that in some degree.
So let's talk a little about that Venn diagram. So I've done prior interviews on PANS and PANDAS. Listeners have some understanding about the condition, but how is PANS and PANDAS different from autism or regressive autism? How are those conditions different from autoimmune encephalitis or basal ganglia encephalitis that you mention in the book? Is there an overlap between the drivers or triggers of PANS and PANDAS and those autoimmune encephalitis or basal ganglia encephalitis type conditions? And do we approach treatment in kind of the same general holistic manner?
Yes. But more in specific, I think, by definition, PANS and PANDAS need to be of an abrupt onset. Yes, there are some subacute presentations, and we can talk about that a little bit later. But by definition, it's an abrupt onset. Regressive autism is not usually as abrupt. With PANS and PANDAS, it's the mother saying they were fine on March 12th, and on March 15th, they were a different kid. Whereas regressive autism, maybe it seemed like they lost it overnight, but it may have been a little bit more prolonged. Also, regressive autism almost always is in the first few years of life. The child is fine till 1 or 18 months, sometimes 2 years, and can be later than that. But again, in that overlapping Venn diagram, the PANS PANDAS kids almost never start before 2. There are some that go lower, but they're usually between 3 and 13. As far as autoimmune encephalitis and basal ganglia encephalitis, why I call it basal ganglia encephalitis is by definition really what it is. It's inflammation of the basal ganglia, the caudate, the putamen, the amygdala, those areas of the brain that get that host response, so that molecular mimicry. So rather than attacking the germ that may have triggered the issue of PANS or PANDAS, it's the antibodies, the proteins that are instead attacking the brain. And I do believe that much of autism is also autoimmune encephalitis. I do believe that there's a huge inflammatory component to their encephalitis or encephalopathy. So, for example, one of the causes of autism may be a viral encephalitis. Okay. That's an autoimmune encephalitis. So that child who gets autism for that reason, it's a very much an overlap. So I think we have to look at each individual. And just because you have autism, regressive or otherwise, doesn't mean you can't get PANS or PANDAS. But they're not the same in that way.
Let's dig in a little bit more to your comments about the bug as compared to the host response. So, how much of the illness in PANS and PANDAS or the symptom presentation is the microbe versus the host response to the microbe? And is it more important to kill a bug or to modulate the immune system to not be so overreactive or hypervigilant?
Both are important, and it's always a three-pronged approach: treating the symptoms, treating the inflammation, or providing immune support, and killing the germ or treating the infection. But of those three, what's often left is treating the inflammation. And if that's not done, then they won't get better because it's that secondary effect. And in my practice, a lot of these kids have seen 7, 13, multiple people, or they've been dealing with this for years before they even realize what it is. And by that point, it usually isn't just about killing the germ. And in those cases, we really try to do it herbally. But it's about providing the immune support and the anti-inflammatory support while we treat the symptoms and help them to get better. So if I had to choose one that was most important, it would be the inflammation.
Many of our listeners will have heard of the Cunningham panel. Some may know of the neural zoomer from Vibrant. Are those key tools in your toolbox when we're looking at the exploration of that autoimmune type response? Or what are some of the tests that you find most supportive of a diagnosis of PANS or PANDAS?
So I first have to say, and I think why it is still so controversial, is that this is a clinical diagnosis. It's because of the set of symptoms that they have, OCD, tics, anxiety, handwriting deterioration, separation anxiety, behavioral regression, abrupt onset ADHD, and then the somatic symptoms of urinary and sleep disturbances or changes, like the kid that starts wetting the bed overnight. So that is what I use. If a child comes in with that abrupt onset of at least two of those, that's the diagnosis, and I don't do anything else. I mean, I will look at their strep titers, their mycoplasma titers, their inflammatory markers, but all from a regular lab, because I'm still that girl from West Virginia. And those other tests are very expensive. And if I can tell somebody that this is it, you don't need any other tests, then only the parent is driving. I want the proof to get the data. Or maybe when I first started out, doing this work, the PANS PANDAS work 15 years ago, I got more tests. But now I use either the neural zoomer or the Cunningham panel when I'm not sure. When it's a subacute presentation, but there was strep in the past and maybe that was more acute and it was just missed. Or I definitely think this is an autoimmune encephalitis. What type of antibodies am I going to see? They both are more accurate when a child is in a flare, though. So if a child comes to me and they're in a good space, I don't do it, even if I want that information. I want them to come back or get it drawn at another time when they are in a flare. But the CAM kinase piece of the Cunningham panel, if that CAM kinase is elevated at 130 or higher, it's almost pathognomonic for PANDAS. However, because strep's only one of them, you can have a normal CAM kinase and it still be PANS. Mycoplasma is not going to raise your CAM kinase, and your other inflammatory markers, because they're not in a flare, may be fine. So I really think about it hard before I do either one. And we were part of the initial studies with some of these tests looking at it. So we did a lot, and it can be very helpful. But just because of the expense, I try to pull back a bit.
In my personal health journey as an adult, I had a Cunningham panel that did show some positives for this autoimmune type presentation. And so that leads me to the question. And by the way, in my case, that was when I had a mold exposure. And so
Right.
what I'm wondering is, can the Cunningham panel be useful in adults? And then the broader question, what are your thoughts on the potential for a PANS-like condition to occur in adults as well?
Right. Great question. So first of all, with pandas, it really should be pediatric, but many of those children with pandas also have PANS because after that first strep presentation, they're then sensitive to viruses or getting their teeth pulled or, a mycoplasma infection. And what really can be missed is Lyme co-infections, and mold. So, especially with Lyme co-infections and mold-induced autoimmune encephalitis, that definitely occurs in adults. When you talk about what's the acronym, it's pediatric abrupt onset neuropsychiatric symptoms. So do I necessarily call it PANS? And by the way, I am a pediatrician because I don't like adults. So, sorry. And so, I personally don't see any adults, but I have two wonderful naturopaths in my practice and a wonderful dietitian, all of whom do see adults. And absolutely, they're seeing these diseases. Would I call it PANS? No, I'd call it autoimmune encephalitis due to whatever it may be.
What portion of PANS would we suggest is genetic versus epigenetic? And is it common to find in the family history other people with autoimmune conditions?
Very common to see other autoimmune conditions. It's in at least 64% of first degree relatives. And when you see it more genetically is when you also go back to the grandparents or the great grandparents and you hear a history of rheumatic fever, or there's multiple generations of autoimmune disease. The 64% of autoimmune disease is just in first degree relatives. So that longer history is very, very common. So I think it's a little bit hard to ferret out if it's genetic or epigenetic. I think it's almost always both, because why do 1 in 200 children rather than 200 children who get a strep infection go on to have pandas? Now, in my practice, it's 1 in 2, but in the general population, they say 1 in 200.
Let's talk a little bit about the role of mitochondrial dysfunction in this population, pandas, PANS, autism. Is there a way that you found to assess for the potential of mitochondrial issues? Can we do that through organic acids or other tools? And do you find that supporting the mitochondria is a needle mover?
Absolutely. And great questions again. Mitochondrial dysfunction is secondary often to many of these conditions. So, for example, autism. We now know that mitochondrial disease is about 4 to 7%, depending on the study of those children. But mitochondrial dysfunction is as much as 85%. And it's because medications like acetaminophen and risperidone cause problems, cause dysfunction of the mitochondria. Germs, dysbiosis that may be causal in the autistic diagnosis also cause problems in the mitochondria. Anesthesia, other medications, illicit drugs, so many things can do that. And then, of course, Lyme co-infections and mold definitely do that. So in almost everybody, we're looking for mitochondrial dysfunction by history, low tone, constipation, the brain fog one, certainly, and also any regressive type behaviors, especially in those regressive autistic children. But mitochondrial dysfunction can be any symptom in any organ. So anything you have. I have a lot of kids with PANS that have presented with like esotropia. So they have strabismus out of the blue. And that is often treated best with mitochondrial support while you're getting rid of the initial trigger. The tests I do, so first history always, second physical exam, do they have low tone? Do they have strabismus? Do they have any other findings? Seizures can be mitochondrial dysfunction. And then I will do regular blood work, regular lab, Quest, LabCorp, local hospital, whatever, for carnitine, acylcarnitine panel, ammonia and lactate, better done fasting, and plasma amino acids, looking at the alanine to lysine ratio. So I will do that in the regular labs. And then, as you said, the urine organic acid is also a great tool, looking at the Krebs cycle and the citric, also called the citric acid cycle, and carnitine function and all of that. So I will also often do that test.
I want to talk a little bit about the tonsils. When I was young, there was no problem finding an ENT that would take out your tonsils. It seems like nowadays there's some difficulty in getting tonsils removed. Wondering, how often does removal of the tonsils lead to symptomatic improvement? And is it a requirement even for some people? And then also, how might the tonsils be a focal driver of autoimmunity associated with Th17?
Absolutely. So Th17 is one of the drivers of the inflammation. And in children with pandas, you find very high levels of Th17 cytokines within the tonsils if you culture for it. That's definitely research proven and definitely can be seen if you can get a pathologist to do it. So going first to your first question, I highly recommend any practitioner that's doing this work, getting to know the people in their area. And I have been lucky enough to get to know of several good ENTs who get this, who will do this, and most importantly, will culture the tonsils and adenoids when they are removed. So, and I trust them to do the right thing, because in my work and in my anecdotal experience, it's a 50-50 proposition, meaning 50% of the kids don't get better and may even get worse, and 50% do get better. So I depend on that ENT to look at the adenoids, to do that good history, to decide for him or herself if they should be removed in that individual case. Now, certainly if a child has recurrent strep infections, sleep apnea with large adenoids, they have other reasons for the tonsils and adenoids to be removed, those kids are going to get better. But otherwise, I really work together with my ENT to make that decision. And I think there are some physicians and other doctors who say, I won't treat this unless you get your tonsils and adenoids removed. And there are even others that say, don't ever get your tonsils and adenoids removed. I always, for my whole life, I've had a foot in both worlds, functional medicine and allopathic. And I look at the child in front of me. So I'd say, in our practice, a little bit less than 40% of the children have had a TNA. And of that 40%, because we're not getting in on all of them, of that 40%, at least 3/4 do see improvement. But we're making a very strategic decision of whether to do it or not.
Your treatment approach, and you mentioned this a bit earlier, consists of removing the inflammatory triggers, which includes microbes, decreasing inflammation to really support and restore the immune competence or immune response, and also addressing symptoms with supportive therapy. So let's dig into some of those. Let's start with the microbes. And you mentioned a few of these: Lyme, coinfections, mycoplasma, and strep, obviously. But what are the primary infectious agents that you find as triggers for PANS and PANDAS?
I think it is regional. In our area, we see a lot of strep. We see as much, if not more, mycoplasma. We've got a lot of mycoplasma in our area. And then viruses. Of the Lyme co-infections, the most common is Bartonella, by far, with neuropsychiatric. And then we're always asking about mold. Once a child has PANDAS, strep-induced neuropsychiatric issues, as I said earlier, they are very likely to have one of these other issues, like viruses. When they get braces on, teeth pulled, when somebody else in the family gets sick with a strep infection and they may just have behavioral symptoms. So those are the most common microbes, but I will put all viruses, including COVID, in there.
So that was actually my next question, which is, are we seeing an increase in PANS in the COVID era? Do we think that it's a common trigger for PANS?
Yes. And we know that COVID causes a post-infectious inflammatory response. And there have been several articles now published on PANS that is COVID triggered. And we have seen this in many children, especially those who have been vaccinated and get COVID within a short time. So especially in the 2 weeks after the vaccine. And they sort of, I think, have a double whammy. And unfortunately, as we are just learning about COVID, we don't have a lot of allopathic medications that are either safe or work. So we use a lot of our antiviral interventions in general, herbally, antioxidants, et cetera, that tend to work well. And I'm hoping that COVID will bring more light to this disease because people are really seeing this. And if we can get them to understand, yeah, but there are all these other microbes and issues that have been causing this for years, let's look at all of them. It may move the needle a little bit.
Given that some of these infections that you mentioned, Lyme, co-infections, potentially others, can be passed from mom to child during pregnancy, how often does congenital transfer set the stage for PANS and PANDAS? Can we have we know it needs to be an acute presentation, but can we have some smoldering, predisposing factors that are already filling the bucket, so to speak, and then a final contributor that triggers that more abrupt onset?
No question. And great way to put it, especially in the children with autism that then go on to have an abrupt onset later. They may well have gestational Lyme or Lyme co-infections. They may also have mold disease that nobody ever realized was a problem. And again, as I said, some of these kids that don't have an acute presentation when I see them, if you really dig deeper in the history, there may be an acute presentation then. But life starts before a child is even conceived. And whatever mom, and to some extent dad, is dealing with in that first 1,000 years of life, which really begins 3 months before conception and goes for the first couple of years. Anything that mom, while she's breastfeeding, while she's pregnant, in those first few months before, is exposed to, inflamed by, can set the stage for later issues with any of these disorders.
How do you balance the use of pharmaceutical antibiotics with natural interventions like you mentioned herbs? Can a child recover without antibiotics at all? And what are some of your top natural antimicrobial interventions?
Right. The naturopaths in my office, because the state of Connecticut hasn't gotten smart enough to change their minds yet, cannot prescribe antibiotics. So certainly whenever they see a child without me, they are not using antibiotics at all. And most of the kids get better. So if I'm seeing a child in the very acute phase, I may well start with an antibiotic like azithromycin. And the main reason is azithromycin has less ability to worsen dysbiosis of other causes. We have a lot of mycoplasma and it treats mycoplasma. And in our area, the strep is sensitive to azithromycin. So I may start with that while I'm waiting for some labs to get back to figure out what the underlying cause is. But then very soon after that, we will often switch to herbals. And we will usually do an antimicrobial rotation so that we're using several different herbs, each for 1 to 2 weeks and switching to the next. And we may start out with 4 of them. We may get down to 2 or 3 because those work the best. Those are when the child really continued to improve. And especially when we're dealing with Lyme disease and Lyme co-infections, I almost always move to herbals and often try to start with herbals rather than antibiotics because we're often dealing with more than one co-infection. And multiple antibiotics is certainly not the way I want to go if I don't have to. The last piece of it is, the cost of all of this to families is very difficult. And sometimes because I will start with an antibiotic to see a more abrupt change, to get the family on board with understanding this, to show them the research, because with PANS and PANDAS, there's a lot more very specific research for that disease in the literature than there is for antimicrobials. The antimicrobials have great research, but not specifically for PANS and PANDAS yet, at least as much as the antibiotics. So I have many different reasons for often starting with it, but my bent is much more toward a functional medicine approach.
So things like you talk about in the book, berberine, neem, usnea, I actually love it's a great resource in the book when people get it that by different type of microbe, you have different herbs that have been most helpful. I think that's just gold. I want to talk
Yeah.
a little bit about your thoughts about the percentage of children or approximate number of children with PANS that you think do have a vector-borne illness contribution. Lyme, co-infections. You already mentioned Bartonella. That's been my observation as well, that maybe is probably the biggest player in vector-borne contribution to PANS. But what are your thoughts about how common this is part of the puzzle?
Well, again, we live in Connecticut. This is where Lyme originated. We've got a plethora of Lyme here. And I would say after strep and mycoplasma viruses, Bartonella is next most common. And then Borrelia and Babesia, and you got to throw mold in there. But we are always looking for it. We're always asking about it. With Bartonella specifically, the symptoms can be sore soles of the feet or kids bunching up their socks, to support their feet. That's something that happens. The striae, the stretch marks that blanch. The neuropsychiatric symptoms, the anxiety, OCD can just be Bartonella, but particularly rage. And then, of course, with any of them, there can be the joint pains, the muscle aches, the fatigue, the mood swings, all of that. With Babesia, we're also looking for air hunger. Some people come in with a tic that really is air hunger, and those are often Babesia or night sweats. Between mold and Babesia, when we hear night sweats, we're looking for one or the other of those. And then with mold, sort of the ice pick sensations, we hear that a lot in kids, as well as, again, the brain fog and all the other symptoms. So we're looking for all of them. I would say 90% of the children in our practice were at least looking for Bartonella. I'd say in 60%, we're looking for all Lyme disease and Lyme co-infections as well as mold. And then we always look for strep, mycoplasma, and consider viruses.
And in that percentage where you're looking for Bartonella, how often are you able to confirm Bartonella is part of the picture?
At least 70% of those.
Wow.
Yeah, it's very common and very often missed.
In the book, you talk about the fact that conventional medicine does not have a lot of options for treating viruses. You do mention amantadine, which was one of the medications years ago that I took that led to some serious depression for a few days. I really ended up having to stop. And so my thought process was maybe it was really hitting some deeper viruses. I mean, I don't know exactly why, but wondering how commonly do you use amantadine, and does it commonly lead a child to higher ground?
Yeah. So it is by no means a first line. Although some of my COVID-induced PANS teenagers do very well with it. But I think there are two reasons for the reaction that you had, for example, and I have seen it 3 times in my practice. And there is a documentation of almost a psychosis or a psychotic depression from amantadine. And if I get something that bad, I automatically tell them to stop it. And I will tell them that when they're starting it. But in some of them, it may be a milder form of a Herxheimer reaction. And that's not what I think you're describing. That's a bad reaction that you have to come off of. But if it's a milder, I'm feeling more anxious, I'm not, my symptoms seem a little bit worse, I try to get them through the Herxheimers with ibuprofen, antihistamines, maybe a little charcoal. But the amantadine is a medication that's been around for decades in the treatment of Parkinson's. And I call it the treating the getting stuckness. So it really can help with the OCD. And the kids that are really triggered by where OCD is their biggest symptoms and it's virally triggered, those kids may well get better with it because it's also a wonderful antiviral and a wonderful anti-inflammatory. But for the large majority of viral induced, I'm using antioxidants, herbals, and then treating the inflammation.
So let's talk then about some of the natural antiviral interventions that you use in your practice. And one that I learned from your book, and I've had lots of conversation now with the company and was excited to learn about, was aqualorin. So I'd love to hear a
Yes.
little bit about how you're approaching this with natural tools.
Yes. Well, to talk to the rep about that, do need a good hour because they will talk your ear off. But monolaurin or lauricidin is a wonderful antiviral that has been around for, many, 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 many years. But this particular form combines that with a biofilm buster that helps to break up. And it was developed first as a biofilm treatment in large industrial like tanks. And one of the gentlemen in the company thought, well, maybe this will work for one of my friends, and started studying it and testing it more against Lyme. But we have now found it to be a wonderful antiviral, a wonderful antifungal, and antimicrobial overall. And one quick story, I had a little girl with autism that, definitely had yeast for years, definitely had viral mediation, and she was much better. But they were about to institute a new plan at school, and she had to get some neuropsych testing. Well, it takes about 3 months to get that planned. And when I saw her, I said, could you please just start this? Just use it for the next 3 months. I've just learned a lot about it, and I think it may help her. That's all they changed. And 3 months later, when they finally did the neuropsych, she had lost her diagnosis. So, yeah, I mean, we all have stories like that. There are a lot of anecdotal things, but I think it is safe. Now, one thing, don't ever show it to a patient like this over your computer, because it is a gel. And I dropped 1 drop on my hard drive and lost my laptop. So
Oh my
anyway,
gosh.
just a little caveat.
Yeah, it is an interesting. I actually got a bottle of it, and it is kind of interesting when you first see the consistency of it, for sure.
Yep.
So in the book, you talk about lots of things: vitamin A, lysine, astragalus, andrographis, many others. I mean, again, this is such a great resource, and I urge people to go and check that out. You also talk about lemon balm, transfer factors, some of the SPMs as well, or the pro-resolving mediators. Let's talk a little about yeast and fungus. So you do talk about fluconazole and terbinafine. Wondering if you use itraconazole at all, and do you find that there's overlap with yeast treatment and fungal colonization from water damage building exposures?
Absolutely. So first of all, I think those that have water damage building exposure, mold mycotoxins, may well do better with itraconazole. And I absolutely use it. The only reason I didn't mention it in the book is because most insurance companies do not cover it in the dosages that you need to get to. And so to offer that up in the first edition, at least, I didn't. And the other thing is all of the azole antifungals can interact with a lot of the medications that these kids get put on. So terbinafine may be the only one that doesn't interact in much the same way. My favorite is still herbals, though, and an herbal rotation. And sometimes with a biofilm buster, an enzyme 15 to 20 minutes before, and then the herbal and rotating the herbals. I find that works really well. But if that fungus, is also associated with water damage buildings, itraconazole is my first stop, and you definitely have to consider both in treating it.
So some of the natural interventions that you're drawn to for fungal and yeast support, what might those include?
Oil of oregano, grapefruit seed extract, caprylic acid, Podarco. And this is also regional. For instance, my patients in Africa do much better with Podarco than oil of oregano. So you sort of got to know the region too. And then enzymes to break it up. There are several different companies that make excellent enzymes. And then also removing it from the diet. A lot of these kids are craving sugar and carbs. And I always talk about it as the enemy army. If you keep feeding the army what it wants, it's not going to die. So you have to starve out the army as well as put in the herbals, which are your handguns and things like that. And sometimes you need the heavier artillery or the big tanks, especially if a child comes to you after being on antibiotics for years for PANDAS or Lyme or whatever. They may first need an antifungal medication before moving on to herbals.
We've talked about the contribution of mold illness or biotoxin illness, chronic inflammatory response syndrome from water damaged building exposures. The SIRS community has suggested that mycoplasma is higher in water damaged buildings. And so I'm wondering, do you think that ongoing mycoplasma exposure could be an association in part with exposure to water damaged buildings at home or at school?
Yes, definitely. And I think in part that is why we have more mycoplasma illness in our area, because we have a lot, we're a shore community or state. There's a lot of water damage in the buildings in this area. And it's a pretty moldy environment with all the trees and especially at this time of year. So that may be one of the reasons we're seeing more mycoplasma here than some of my colleagues in other areas of the country. So there is definitely an association.
I've mentioned that in the book, for each of the different types of microbes that play a role in PANS, you have a number of pharmaceutical and herbal options. I'm personally a huge fan of herbs as well. You mentioned colloidal silver in the book. And one of the things I wanted to get your thoughts on was I tend to think of herbs as being somewhat intelligent, affecting more of the pathogenic organisms than the health promoting microbiome organisms. And I'm wondering, do you think that colloidal silver is also selective in that way, or do we need to use it shorter term because of any potential negative implication on the microbiome?
Excellent question again. And I think that is the one that we do need to watch because it can be more like antibiotics in depleting the microbiome. So yes, when I use it, I only use it for a week, maximum 2 weeks, and then move on to other herbals. If it were the best player, because it does get mycoplasma as well as strep, I may come back to it in rotation, but I'm always watching the microbiome very carefully. And again, as much as, I come from two physician parents, my whole life was allopathic medicine until I went through infertility. What I have learned over the last 30 years, I wish I had become a naturopath because it is so much more healing and there's so much more potential out of herbs than out of antibiotics, for example, just because of the anti-inflammatory components, what you say in not depleting the beneficial flora within the gut, and just the overall better scope. Because so many of these children have more than one microbe that caused it. Just treating one microbe, you're usually missing a lot.
In pandas, where we know that strep is the trigger, what are some of the hidden reservoirs that you find for strep? Can other family members play a role? How about pets? And how common is it that you need to look outside of the patient to have a more comprehensive treatment response?
We always look outside the patient. But first, there are many reservoirs, not just the throat, the tonsils, and the adenoids. Think about the sinuses. But I often see cryptic sinus infections as being mold or yeast, but it can be strep. Think about not just the gut, but the anus. In the literature, it's 7%. In our population, it's 20% of kids have rectal or perianal strep. So make sure you're looking for that. The red anal ring is a classic sign. And then sometimes the urinary tract, sometimes the skin, all of those areas. But it is very common for a sibling, more than parents or dogs, for a sibling to have a strep infection, and the index case only, the child in front of me only get neurobehavioral symptoms. So I always encourage parents to look at the anus, to look for other signs of infection, and to do a strep culture if anybody else in the family does it. Then I also encourage families to get everybody checked if the child's not getting better, to get strep titers, ASO and anti-DNase-B, to get mycoplasma titers, IgM and IgG, and get inflammatory markers and make sure there aren't other carriers, as those blood tests as well as the strep culture. And then finally, close contacts, the best friend at school and other things that are going on. A child that gets braces placed and isn't brushing their teeth as well may well be housing strep within their mouth. And we have to remember that the gut starts in the nose and mouth. So we've got to treat the nose and mouth, whether it be with xylitol, nasal sprays in the mouth around those braces or oral probiotics to clean out that area.
In the book, you say that while inflammation is the result of autoimmunity in these conditions, we have to address the inflammation. So, what are some of the top tools for putting out the brain on fire, as Dr. Mary Ackerley often refers to it? And then several listeners ask what works best as a rescue for flares. I know you mentioned ibuprofen already, antihistamines already. Interested in your thoughts on anti-inflammatory interventions.
Right. And I will look at the child in front of me first. For example, if it's COVID induced, if it's allergy induced, I may start with quercetin. If there are some lovely curcumin products that are very effective, the thing with curcumin is you need to make sure that it's the most bioavailable form. And I have been known as a brand snob because brand does matter.
And feel free, you can mention any brands if you like. I'm happy.
Nutrimetics makes a very good product called Avea, which is a well-researched bioavailable form of curcumin, and it's very good for anxiety and as an anti-inflammatory, and can be used 10 drops every hour in those acute situations. So that's one I love. There are many forms of quercetin that are very good, and several in combination products. As antihistamines, I like Dehist and Histes, and then also resveratrol. Resveratrol is naturally occurring in Japanese knotweed, which is by far my favorite for Bartonella and Borrelia, but also having the resveratrol makes it very effective. That aquilaurin we talked about has one form that has resveratrol in it. So that's another one that's got anti-inflammatories in it. So those are my top ones. I will use ibuprofen because I haven't found any herb, antioxidant, and natural anti-inflammatory that can work in a flare as well as ibuprofen. But I will use that and then try to move on to all the others. SPM, active or SPM Supreme are also wonderful specialized pro-resolving mediators. I very rarely use steroids. I can count on two hands in 25 years, however many times I've used it. I think there usually is the worsening because these kids have multiple dysbiosis, and it especially feeds the yeast dysbiosis, but also Clostridia. I think roid rage is a real thing, but again, I think that's because of dysbiosis. And only when none of these other things have worked, or I have a family that's so allopathically minded, that's the only thing that they'll do, will I do that. And it is helpful in saying the child that gets better with steroids may well be the child that needs to move on to IVIG.
Are these conditions more Th2, Th17 dominant conditions? Do we generally see a lack of Th1 and Treg presence or activity? And what are some of the tools that you found most helpful for immune modulation?
Yes, that's absolutely true. And again, another great marker. And I do find that they are Th2 and Th17 dominant. And I can't say that I feel that any specific herb and I'm happy to be educated, or nutraceutical has been better than another in those cases. It's more the history of the child that has driven me. I think all of these kids are Th2, not all, a large majority are Th2 and Th17 dominant. In the pharmaceutical industry, I have found cromolyn sodium to be very helpful, hydroxyzine, cyproheptadine, and ketotifen, specifically in those kids. And then when I look at antihistamines, I'm also looking at those combination products and the quercetin in those kids.
Yeah, it's interesting in the immune modulation realm. I've been really interested in this in the COVID era. And I would say black seed oil has been one that's come up a lot for me, is very interesting. And then a lot of people seem to, and maybe in kids this may not be as appropriate, but a lot of adults, low dose naltrexone seems to be really helping with some of that immune modulation.
Very good point. And we do use a lot of low dose naltrexone. We will often start with a cream, again, because the kids come in with a lot of gut problems. And, we're trying to avoid the gut initially until we get it a little bit better healed. But we will also do it in very low dose. Yeah, low dose naltrexone. I'm only becoming familiar and using more of the black seed oil, and it's a great one. And I think that's a wonderful point. And I'll take that one home.
I know so many people over the years that have talked about Th1, Th2, Th17, Treg. The challenge, as I've understood it, has been that there weren't really any fantastic ways to look at this. I know the Cyrex lymphocyte map is a newer tool in this realm, and wondering if that's something that you've explored in your patient population.
Certainly in the same way I use the neural zoomer and the Cunningham panel, if I'm not sure and I want more information. About 30% in this group will have immune deficiency. And those are kids specifically that do better with the specialized pro-resolving mediators. I think there is good research that the Th17 is high in these kids, but you're right. I haven't quite found a test that I believe in enough, though I love Cyrex and will use them. Again, it's only when things aren't getting better that I turn to it.
You are a leading expert on the use of helminth therapy for immune modulation, which really came out of your work with your mentor, Dr. Sid Baker, that you mentioned. So these HDCs are, as I understand them, a type of tapeworm that are found on grain beetles that used to, this was very interesting to me, used to be part of our diet over 100 years ago. And so maybe another reason that we're seeing so much immune dysregulation. Wondering if you can talk to us about how helminths can balance or modulate the immune response, and what's the general response to this HDC therapy in your patients? Are there any potential side effects we need to think about?
Yep, great question. So I am a believer in it in that I think it induces immune tolerance. So the idea is that evolutionarily, we all used to dry our grains in large vats. And when we dried them without processing them, there were grain beetles there and grain beetle worm eggs. So we always ate that. When you look at the rate of autoimmune disease, you have to get over the ick factor, Scott. When you look at autoimmune disease, it is much more prevalent in industrialized societies than in pre-industrial societies. And this is one of the factors that is considered important in why that may be. And, in industrialized society, it's not just about antibacterial soaps and antibiotics. It's about wearing shoes, using toilets, not living in the dirt as we all should all the time. So this brings back in that grain beetle worm egg that doesn't cause an infection ever in anyone and should not cause an infestation, especially in adults. And an infestation is where the egg hatches and becomes a worm before it's excreted out. What instead happens is the immune system sees it, says, aha, I know this, and induces that immune tolerance. And quick little story, William Parker is a wonderful researcher at Duke, and he used to catch wild rats as a little kid behind restaurants to make money. So when he was a PhD, when he was first trying to get started, didn't want to use all his money for lab rats, but so went and caught wild rats. And he found that his wild rats were smarter, learned the mazes faster, were healthier, and had less rat OCD and anxiety. And that's how he first started studying this. It's used in inflammatory bowel disease. It's used in other autoimmune diseases. It is very safe in adults. In children, there's a 1 in 1,000 risk of the egg hatching before it's excreted. And so I am very careful for who I use it in. I do not use it, although it is a mutualist and not a parasite. I do not use it in children that I think have parasites, that have worsening of behaviors around the full moon, or I've actually grown a parasite in the stool until I fully treated that. I will not use it in children that are constipated, because if you're constipated, you're less likely to excrete it before it hatches. I will not use it in any children that are on any immunosuppressive drugs, including IVIG, unless their IVIG is so spread out that we can do it sort of in between. And I will no longer use it on nonverbal children that already have gut problems, because they can't tell us that the infestation is very easy to treat. It's 1 day of Biltricide that'll never change. These guys don't develop sensitivity like bacteria and other things do. So it's really easy to treat. But a nonverbal autistic child, for instance, who already has gut problems, that causes me pause. But if a family can't get IVIG, if they can't afford it, they can't get their insurance to cover it, this is something I will consider after, and this is where, for instance, that Cyrex test may come in, after I prove they're not Th2 dominant to too much of a degree, because that can make it also not work as well.
And that was going to be my next question. So in the book, you mentioned that these HDCs stimulate Th2. So it sounds like in those children that you already think are Th2 dominant, that there's some things you're doing first to do the immune modulation so they then can better tolerate this type of an intervention.
Right. So, but it was the first, and it also is an intervention that definitely causes a Herxheimer reaction. So I urge people to, if they're going to consider it, to do it with a practitioner. With everything we do, I urge people to start low, increase slowly, and get to the full dose after you've done it in that way. A lot of people want to jump in with 2 feet and they'll get a bad reaction. And part of that is because you need to build up to that.
Aside from these parasites or HDCs that we're intentionally ingesting for purposes of immune modulation, might it be the case that other parasites that we get exposed to also have some immunomodulating properties? And should we always be trying to kill every other parasite that might be in our bodies?
No, not at all. We should not be trying to kill them. There are some that are definitely problematic. Certainly if they're causing diarrhea, they're problematic. But what I first look at is this child having symptoms that are related to parasites? And if they're teeth grinding, butt grinding, and having bizarre, out of control behaviors around the new and full moons, those are kids that I think need to be treated, even if it's blastocystis hominis, which in most of us, shouldn't be treated. We're fine. But again, it's our individual ecosystems that are so depleted. And if we try to kill every bug in our guts, we're doing the absolute opposite of what we should be doing. It's fertilizing. We need to promote all types of germs, including yeast, parasites, and Clostridia, but in balance with the beneficial microbes too.
These SPMs or pro-resolving mediators that you've talked about, they're shown to inhibit the NLRP3 inflammasome. Melatonin also does this, as I understand. So I'm wondering if you find in some of these kids that melatonin can also be helpful with modulating the inflammation.
Yes, absolutely. And we saw that with COVID. There's good research that melatonin helped to decrease the inflammation with COVID. And melatonin is often one of our first line interventions, especially if a child has sleep problems, but has multiple benefits as an anti-inflammatory as well as a calming agent.
Sounds like you've come across some of Doris Lowe's research, I'm guessing, because that's where I read about it too. Yeah. Is there a place for peptides in immune modulation in PANS and PANDAS, things like thymosin alpha-1, thymosin beta-4, BPC-157, KPV, any of those that are helpful in this population?
It's a great question. And I think, in all honesty, I think I'm a little bit more of an outlier there than most of my colleagues that treat these kids, because I have yet to see a real remarkable improvement. But many of my very bright colleagues, Scott Antoine in the Midwest, Tom Moorcroft here in Connecticut, have had very good success with these peptides. And I've tried many and I'm learning more and more. And that's my big plan over the next 6 months, is to give it another really good trial. Because the first time I did it, mainly with the thymosin alpha, I didn't have the effects that I wanted to in many of those kids. So I'm reinvigorating myself, but I do think it could be very helpful.
How about low-dose immunotherapy? I know Dr. Amy Dirksen, for example, has found that helpful, as have others in strep and dealing with some of the contributors to PANS as well. Is that something that you've used in your patients?
We don't do it in our practice, only because Darren Ingalls used to be right down the street, and his practice is now Jaquel Patterson's. He's out in California. But we refer to them quite frequently, and we do find it helpful. Again, I get a population that is dipping their toe into functional medicine, and I bring them in, but they come to me because I have those other initials behind my name. So I have to urge them to do LDI rather than start with that because of what they're coming to see. But that's part of the listening and treating the individual child. And a lot of times I will tell other allopathic physicians, neurologists, psychiatrists that say, why are you doing this? This is ridiculous. Functional medicine never works. I'm like, let me develop a relationship with this family. If they really need what you're offering, they'll come back, but let's just give it a try. And so I say to the families in the same way, LDI can be very effective. Let's give it a try.
I was just having a conversation with Dr. Ingalls right before we started our conversation. So he's somebody I definitely respect a lot as well. Oxidation is part of the body's response to infections. In the book, you talk about the importance of antioxidants like vitamin A and C, D, zinc, resveratrol, melatonin, glutathione. Do you think that these have to be minimized early on when we're doing the microbial management stage of recovery? Can we have too many antioxidants and essentially kind of negate the body's own oxidative response to some of these pathogens and lead to other problems, maybe even cancer in some cases?
Great questions. And again, think it's very individualized. So if a child comes in with very low vitamin D levels, and I will check that at the initial visit every time, or very low vitamin A levels, then they need it. And I will follow those levels. NAC, for example, which is one of the building blocks of glutathione, has 17 studies behind it in the treatment of OCD. What's the problem with NAC is that when you open it and expose it to the air, it oxidizes. So that oxidation absolutely can negatively impact them. But I do believe that as long as it's individualized, antioxidants are necessary, but you're absolutely right. We need to make sure it's only as necessary and that we're treating the microbes and the immune support first in almost all cases.
Do you find that the majority of children that you work with tolerate glutathione? I know in the Lyme and mold illness population, some people can be sensitive to it if they're dealing with sulfur pathway issues. Wondering in those children that maybe don't tolerate it initially, does adding molybdenum increase glutathione tolerance?
It does increase glutathione tolerance, absolutely. And we do find, occasionally I will give IV glutathione at their initial visit when I'm drawing their blood. If I really think that they're impacted in that way, either because of their DNA methylation or something else from their history. If they then go on to have a negative reaction, I will always find their molybdenum low in their RBC minerals. So, that is very true. And I think that we have to, again, look at those children and not do it for everybody, because certainly the kids where their mycotoxin may be more ochratoxin driven as opposed to gliotoxins, those kids won't tolerate glutathione as well. And we need to look at that in their tests. So it's not usual. Sometimes NAC is a first line, but glutathione is not usually a first line in our practice till we get more studies and understand this kid better.
You've mentioned using antihistamines earlier in the conversation. How much of the inflammatory burden do you think overlaps with mast cell activation syndrome, maybe even glial activation? Sounds like antihistamines do provide some benefits in some cases. And do you find that early on that maybe we have to withhold some things like bone broth or fermented foods until that mast cell component has been addressed?
Look, mast cell activation is part of our inflammatory response. We've seen that especially with COVID. So we will see mast cell activation in most of these kids. I have a section in the inflammatory chapter all on mast cell activation. But do they actually have mast cell mediated disease? And those are the kids that really have the flushing and more symptoms. I think if they have mold disease, then they usually have mast cell mediated disease. And I do feel that in that anti-inflammatory realm, we need to use those antihistamines more because the mast cells are a bigger factor. But I think it's almost become sort of, I have mast cell activation syndrome. Well, let's back up. You have mast cell activation. You just had your PANS induced by COVID or allergies or whatever. That's one thing. And let's treat that in this way. But let's reserve judgment that this is really a mast cell mediated disorder that's going to be long lasting. So it's sort of like that mitochondrial dysfunction. It's not all disease. There is that issue, but we have to ferret out which is which, I think.
I 100% agree. I tend to think of mast cell activation as a symptom of the underlying problem or trigger, or as Dr. Richard Horowitz would say, the nail in the foot, but not in and of itself the underlying trigger. So I love how you said that. I want to talk a little bit about diet. And in the book, you talk about low histamine, low glutamate, low phenol, low salicylate, oxalate, the simple carbohydrate diet, the GAPS diet, low FODMAP. I know that everyone is going to be very individual when it comes to diet, but in all of the people that you've worked with, are there a couple of diets that are kind of standouts or not?
Yes. So first of all, 20% of children with PANS and PANDAS will present with a restrictive eating disorder. So we have to be careful about what we're changing in the diet very early on, especially in those teenage kids. In those kids, I will really try to just push an anti-inflammatory diet, which in me, we should all be eating more vegetables, some fruits, less carbs, more good proteins, and eating and more oils and eating in that way. So that's my go-to overall. I think every child that comes into our practice with autism should have at least done a trial of gluten-free and casein-free for 3 months, 100%. And a doctor once said to me, do whatever you need to do so that you have no regrets 5 years from now. And I say to parents all the time, as a practitioner and as a mom, if I didn't do it, I would regret it. So that is kind of universal. In the child with dysbiosis, particularly yeast dysbiosis or even mold-mediated disease, I will talk about GAPS and specific carbohydrate diet if they're not getting better, and really try to focus on removing all of those things that may induce that in their gut. And those aren't long-term diets, in my opinion. Those are 9-month diets. But I do think we have to watch, especially because of the histamines and all of that in our inflamed kids, really pushing bone broths and fermented foods early on in these children. And I might add that later once their guts are in a little bit better shape, but I will almost always encourage parents to make their own bone broth, because I think some of the MSG and some of the problems with the bone broth comes from the commercial branding. But we have a dietitian in our practice and we try to get so many of our children. I have 2 new patients I'm seeing tomorrow, one of who I think needs to be on a fail-safe diet, which is the free of amines, low salicylate, flavor enhancers, all of that. And the other of whom I think needs to go on a ketogenic diet. So, it is individualized, but those are my overall sort of parameters.
In our last section of our conversation, we're going to talk a little about some of the symptom management pieces. So, interested in what tools you find most helpful for OCD, for anxiety, and are these potentially also the result of neuroinflammation?
Absolutely a result of neuroinflammation, particularly the tics and the OCD and the anxiety. No question. And the brain fog. I mean, all of them are neuroinflammation. So again, 3-pronged approach. And treat the inflammation has to be part of it. As I said earlier, NAC has the most studies with treating OCD, skin picking, gambling, trichotillomania, all of those OCD types of things. But I use a lot of herbals, a lot of adaptogens in these kids with anxiety and tics and OCD, things like ashwagandha, rhodiola. I'll use lemon balm, passion flower, nervine tinctures, as well as adaptogens. If a child doesn't come to me on SSRIs, we do use 5-HTP because it can be very calming for all of those symptoms. When it comes to the brain fog, which is, as you and I both know, a grab bag kind of symptom, that is almost always mitochondrial dysfunction, inflammation, and a lot of those kids have mold or Lyme. And we will definitely look for that in those. So
As someone who myself has a history of a little bit of OCD, it's funny, I was sitting here picking my fingers as you said skin picking.
It is. I mean,
well.
My son was 18 months old and he was afraid of mascots. And I left him with my sister for a weekend, and her husband worked for a local hockey team. He was the general manager, and it happened to be the hockey team's mascot's birthday. So because my son was with her, he was surrounded for a weekend by 18 mascots, and he had no skin left on his fingers. And that goes back to that epigenetics, genetics. I have a little OCD. My son probably had a little anxiety early on. And so, he got this disease. And, it's all part of it. But there are many, many different nutraceuticals I'm not mentioning that are also very, very helpful. B vitamins, great for brain fog. Inositol, which is called a B vitamin, but really isn't. The biggest problem with that is the high dosages that are really needed, up to 18 grams to make that effective. There are some products that are now on back order that can be really helpful, but GABA, anti-glutamates, can be really helpful for OCD. So there are a lot of them, and I rarely use medications because most of these kids can get better with a combination of nutraceuticals.
I use my OCD to my advantage. So
exactly. So do I. That's why I get so much done.
You talk about ticks, and here we're talking about TICS for people listening, not ticks as in vector-borne conditions. The potential for microbes to be a contributor to or trigger for ticks, pesticides you mentioned in the book as well. Wondering if you've seen toxoplasma playing a role in some children that are dealing with ticks.
It's very interesting. And I think I probably don't test for it enough, but I have seen it. And again, I'm not treating it with medication. I think I need to look for it more because it is definitely there. But microbes in general can be a cause of ticks, and the gut has to be healed first, in addition to all the other things I talk about in treating ticks. And with that gut goes lifestyle. It's not just about the diet. It's about the yoga or the meditation or the mantras or all of those things that calm the nervous system. So.
I guess my mentor, Dr. Dietrich Klinghardt, probably would not be happy with me if I didn't ask how important is reduction of EMFs in dealing with some of these symptoms in these children.
No question. And that, especially during COVID, was a big driver in a lot of our anxiety, OCD, and tics. And we spend a lot of time talking to parents about decreasing screen time, about decreasing EMF exposure, particularly in the bedroom. These kids are going to bed with their iPhones. They're using digital devices, in their bedrooms. And I'm like, okay, even if you're using something like that to get to sleep, because you got to do this app to get them to sleep or whatever it is, turn it off when you go to bed. Put it on a grounding, use earthing mats, think about what's on the other side of the wall of your child's bed. Is it the refrigerator? Is it the TV? Move it. There's so much of that is important in our children's lives. And going back to one of your first questions, one of the drivers for why so many more of our kids are sick, because the exposure, we're now at 5G. When I started, we were at 3G.
I was recently surprised that I bought a ceiling fan for my bedroom and didn't think much of it, and noticed on my cell phone that the ceiling fan was broadcasting Wi-Fi, not just trying to connect to Wi-Fi, it was actually broadcasting its own Wi-Fi network. And so I very quickly took care of that because why would I want to sleep under that? It just doesn't make sense.
Exactly.
Constipation, in my mind, is so critical for detoxification. The vagus nerve can play a role in constipation. What do you find are some of the more common causes of constipation and tools to get with the flow?
Yep. Oh, nice. I like that. Polyvagal theory, by the way, is very important in these kids with anxiety, OCD, and tics. And I really like the work of Stephen Porges and others that have looked at that. So that's another topic. But constipation has to be treated first. Sometimes it's the germs that don't want to get out. They're loving the warm, moist environment where they're living. So they induce constipation. Others, like Clostridia, want to smear all over the place, and you get stool smearing because, as Derek McFabe has said, you want that microbe all out there. But constipation can be driven by, forced potty training, can be driven by mold, definitely can be driven by mitochondrial dysfunction, by the microbes, and many different things. But it has to be treated, especially before antimicrobial treatment, because otherwise you'll just get a more significant die-off. So we use a lot of aloe in the treatment of constipation, a lot of magnesium. Magnesium's another one I didn't mention, especially for tics, but also anxiety and OCD. We use a lot of fluids and fiber, sometimes vitamin C, although vitamin C can be activating to some of our kids. And then good physical, manipulation. This is where the best form of parenting, bribery, can come in, and sitting with the stool to be in the best position. Because what do we do to a lot of these little kids? We put them on the toilet with their feet dangling. They're going to get constipated just by sitting there.
And I love you mentioned the magnesium, but you also mentioned in the book that even Epsom salt baths, which are magnesium sulfate, that those can be helpful in dealing with constipation as well. My mentor, Dr. Neil Nathan, recently turned me on to the TTFD form of thiamine for dysautonomias, mitochondrial support, many other conditions, the work of Dr. Derek Lonsdale and Dr. Chandler Mars. Wondering if that's something that you've explored in this population.
Absolutely. And thiamine is one of our treatments of mitochondrial dysfunction. And I think the TTFD formulation is much more bioavailable. So Neil's right, as usual.
I love it. This whole conversation, I'm having so much fun. I just love you. In adults with Lyme disease and mold illness, limbic system impairment can play a major role in many symptoms, including some of the dysautonomias. Wondering if you do any interventions in the limbic system realm in children, and what are some tools that maybe can be used in this younger population?
Yeah, it's an interesting question, because I think a lot of, especially the adults who may have been dealing with it for much longer, have a lot of adrenal insufficiency and limbic, issues. The kids, not quite as much, although the teenagers, much more. And I think the even more natural interventions, the going back to doing the yoga, to doing the polyvagal theory treatments, the listening therapies, the meditation, and kids can do that. I also am a big believer in treating dysautonomia in general with fluids, salt, which is often missing, and physical manipulation. I think the limbic system in particular does very well with chiropractic manipulation, with craniosacral manipulation, and even with some of the isometric, isotonic type of exercising. So I think those are all really important.
And so the listening therapy, since you mentioned Stephen Porges's work with polyvagal therapy, I'm guessing that's the safe and sound protocol that can be helpful for some of these kids. Beautiful, beautiful. Wondering if you found any role for FMT, or fecal microbiota transplantation. We talked a bit about the microbiome and how the HDCs potentially help with modulating the immune system. I've been kind of on the fence about FMT personally. I know there can be some pluses and also some potential side effects. What are your thoughts on that?
So, first of all, in my opinion, the best FMT is a relative that has similar genetics, but has never had antibiotics, has never been vaccinated, and lives a healthy lifestyle. Pretty hard to find.
Good luck.
Yeah. The second thing is fecal transplant in this country, at least, really just hasn't happened since COVID. And it really is only available in good places for Clostridia. And then it's one and done. If you have Clostridia resistant, or Clostridia that is resistant to other treatment, FMT can be life-changing, and it's one and done. But for other gut problems, particularly autism, remember that just like our stem cells rejuvenate every 120 days, our stool rejuvenates every 3 days. So you do a fecal transplant, you may make some changes, but 3 days later, you may be back in the same spot. And so most of my families that have had success with it have had to repeat it many times. And then, are you really doing the right thing? Can we not go back and do this with diet and lifestyle changes? So sometimes I'll have families use it and they'll see a benefit. They'll say, okay, that means we got to work on the gut. Let's go back and do all these other things again. And, all of us in our world today are looking for quick fixes. And in the world that I live in, it's always a marathon, not a sprint.
Totally
And,
agree. Yeah.
and if you treat it as a sprint, they're not going to get better.
Yeah, I totally agree. And even you mentioned stem cells. And that's been my personal experience. If we're looking, and I did stem cells many, many years ago in Panama, didn't personally find it to be helpful at the time. I think a lot of times people that are interested in stem cell therapy for systemic healing, now if you have a bad knee or bad hip or something like that, it maybe makes more sense. But I think when we're thinking about stem cells, a lot of times we're thinking, okay, well, if we just do the next expensive thing, it's a get out of jail free card, and I don't have to do a lot of these foundational things like you're talking about. And in my experience, stem cells haven't been a huge winner in adults with Lyme and mold and those types of things, but wondering if that's similar in your patient population.
Absolutely. Exactly what you said. And I think there is that placebo effect that the more money you spend, the more you want something to work, the more invested you are in it. And I think that when you look for that quick fix, I have yet to see a patient that has had a long-term marked improvement, except for a couple that did autologous transplants at Duke, et cetera, under research studies. I've seen several with transient improvements, and then, they go back and spend another $10,000 to do it a second time and a third time and a fourth time until they're either out of money or out of patients. But I urge any of my patients or anybody else that has had that remarkable turnaround to let me know, because I haven't seen it.
Given the impact that PANS and PANDAS have on siblings and parents, what do you recommend to support the health of the entire family unit?
Yeah. Well, my colleague, Dr. Wells, wrote the children's book behind me, which is really, it's Super Sam and the fight against PAN and PANDAS. And it's really for the siblings, because we have to keep in mind that all the children in the family need to be treated. So number one, this is genetic and epigenetic. So keep that other child in mind, because we have several families where there's an index case, but then the other sibling and the other sibling also develop, not the anxiety of looking for it, every moment of every day, but also very important to carve out time with each child as a parent and to have special time with the non-index child. And then lastly, to not feed the beast. That is really important. That child with PANS is still a child in your family and needs to have chores and needs to have responsibilities and does not need to be coddled. And my son may say I push that too hard, but that's okay. He's getting his PhD right now. So maybe it worked. But anyway, it is one of those things that I'm very passionate about, good parenting as well. And I actually sent my son a text the other day to thank him for teaching me how to be a good parent in these circumstances, because I was realizing several of the portal messages, the EMR messages I was getting from parents had nothing to do with medicine. I had just given them a parent technique to help their kids get better. And, I always say the greatest instrument we have in our office is a tissue box. It really, because it's about listening and hearing what the parents and the child are struggling with and being a resource. I have lots of kids with autism I haven't helped. And I said to one the other day, why do you keep coming? What? And she said, you're the only one that listens. I come to just talk for an hour.
I think it's so important, having myself, dealt with chronic Lyme starting, 20 plus years ago. I finally was diagnosed 17 years ago. And just that invalidation that you go through, having so many people in the medical profession tell you that you need to go to a psychiatrist and all of those things. And then I think in some ways, I think that PANS and PANDAS are kind of where chronic Lyme was 15 years ago in terms
Yeah,
of not a lot of people really understanding it, accepting it, believing in it. There's so much invalidation of parents and children. I think in the Lyme community, it's not perfect, but it's advanced quite a lot. I mean, anyone you talk to now knows someone that had Lyme disease. And so I think that PANS, PANDAS, and Morgellons is another condition that's kind of similar, where there's just a lot of
absolutely.
invalidation. And so it's wonderful that, people like you and many other amazing people are moving PANS and PANDAS forward so that people can get that validation and get past that and get to finding the solutions that are going to help heal their children.
Yeah.
Once a child has recovered, what does maintenance look like? How do we address potential exposures in school environments like a strep exposure or a mold exposure that could re-trigger that immune dysregulation? Are some kids on prophylactic antibiotics or herbs? And then do many of these children go on to lead completely normal, healthy lives? Or do they have to be like I do? Do they have to be careful about their external environment, about mold exposures, about chronic infections, those kinds of things?
All great questions. And I think, first of all, we all should be vigilant, and these children are susceptible. I think the earlier we treat them, the better the outcome. And a lot of the kids that have pandas and are treated early and get better quickly may not have that lifelong issue. But those that don't get treated quickly, or certainly those with Lyme and co-infections and mold, we always have to be, alert to that. I think one of the things is, once a child gets better, what's most important is not just to stop everything like that. A lot of allopathic physicians, even the ones that get it, will put kids on antibiotics, they get better, and then they'll just stop. And that's it. Goodbye. You need to, if you're on antibiotics, you need to wean them, particularly the azithromycin. You can go from 1 per day to 1 per week. Several kids will do that. And that's when we're adding the herbals to get them off the antibiotics at all. Where if we started with herbals, we may try to wean down the dose, but we will often do this for at least a year, sometimes 2 years after the symptoms have resolved. And the literature shows that we should continue prophylaxis in children that get this disease early in life till puberty, and those who get it around puberty or after puberty till age 21, because that's when the blood-brain barrier closes. And so they need to have some support during that period of time. Many parents stop it because of either the expense or the kid won't take it anymore, and then they'll get a recurrence, and the second and third recurrence can be much worse than the first. And especially if that happens in the teen years and they're less likely to be, on target with what they're doing, those kids will linger well into adulthood and are much more susceptible later. So it's about weaning the interventions, and it's about figuring out what the trigger is and letting the parents know what the other triggers may be. You get bit by a Lyme tick, contact us immediately so we can tell you what to do. Homeopathically, naturally, or if you have to, an antibiotic. If you get if you get a viral infection or get exposed to somebody with a virus, we have an acute viral protocol that we give people at their first visit to start as soon as they get a virus. We talk to them about when they get braces on. We talk to them about mold, all of those things so that they may be prepared. I think we have to do a better job of providing that in writing too, because most people in that first visit, which for us are 2 or 3 hours long, they're overwhelmed by the end, and they're trying to get at, what do I need to do now? Not what ifs later on. And so we need to keep getting that information out there so that people do remember what to do if something else triggers it later.
Let's talk about some resources that parents and even practitioners can find to really help them understand this condition, to really support their recovery journey. Where can they find more information? I understand you also are putting together a number of resources besides your amazing new book, Demystifying PANS and PANDAS, which I really encourage everyone to read. So tell us a little bit about some of the resources that are available and those that you're creating.
So the ones that I'm creating, in addition to the book, are a mentorship program where I will mentor practitioners of any ilk. And I learn from them too, certainly naturopaths, DOs, and MDs, but chiropractors, therapists, teachers, nurses, nurse practitioners, physicians assistants, anybody that can care for and wants to learn more about this disease. And that's one-on-one or in a group setting. And I also have live Q&As going on, and come to wonderful podcasts like this one to spread the word. And then I have a membership program, which is something that you do on your own time, which has 30 different videos. And every year we'll have 30 new ones about how to do the exam, different products that I use in nutraceuticals and herbals, different medications. It includes the dosages and things like that. And parents can certainly sign up for that too, although I encourage parents to really work with a practitioner. There are many wonderful practitioners across. They may not all be MDs, but again, I am in love with naturopathy and really feel there's a tremendous amount that people can do working with other practitioners and working in nutraceuticals and herbals and not medications. So there's a lot. You can go to my website, which is just drO'Hara.com, and find out all of that. On my website is also other wonderful books. There's a wonderful one coming out by Jill Krista, who we both know. There is also children's books like Dr. Wells, books for teens on my website. There's one about climate change where one of the central characters has Lyme and is just being treated with psychiatric medications until somebody realizes that this is Lyme disease and let's do something different to help this kid be able to do all the other projects that they're trying to do for climate change. So there are a lot of those resources on my website. There are also a lot of different groups, for autism, certainly TACA and NAA, for practitioners learning about autism, MedMaps, which is Medical Academy of Pediatric Special Needs, certainly ILADS for Lyme, certainly Neil Nathan's book, Toxic for mold disease, and using all of those different resources. And then parent groups. I do think the chat rooms and the parent groups have a lot of validity and a lot of purpose. I caution somebody in using something they've heard about in a chat room without talking to a practitioner. I think you need to give it the sniff test with somebody qualified to know more about it and to be a little bit more removed, even though most of us in the field have dealt with it personally, either ourselves or in our own children.
My last question is the same for every guest, and that is, what are some of the key things that you do on a daily basis in support of your own health?
Well, I live by the water. The water is healing for me. It's calming and it's also empowering. So I go for a walk on the beach every day. I do yoga every day, including planks and savasana. And I try to end with meditation, but I think I do the mantras really well. For me, it is always, God grant me the serenity to accept the things I cannot change, the courage to change the things I can, the wisdom to know the difference, but particularly the serenity piece and breathing. I can't tell you how many times I need to take a deep breath, whether it be alternate nasal breathing or just, 7-1, 4, whatever it is. I used to be a runner, but my knees and my back don't let me do that. But now I've given myself more time to walk and to meditate, and sometimes to think, and sometimes to loop in my brain. And some of that also is just forgiving myself, knowing myself, not cutting myself down every day. We can do this, but it takes a village, and I can't do it all myself, nor should I. And then finally, I do have celiac, so I have a very healthy diet, much healthier than my husband would ever want. But do allow myself that glass of wine. I don't beat myself up for the indulgences I have every now and then, though if they're never of the gluten variety or the dairy variety at this point, but a dark chocolate every now and then, one of Dr. Wells' chocolate avocado puddings. Amazing.
I'm going to have to learn about that.
You will.
This was such a fantastic conversation. This was the first time that you and I have had the opportunity to speak. And I was so touched by the pureness of your intention, the purity of your heart. I was touched by your spirit, everything that you're doing to help these kids. And so I just want to honor you, not for just being here and sharing your wisdom and your time and all of that for really for the work that you do, the amazing work you do for these children, and for everything that you do to help minimize the struggle and suffering of these kids. So thank you so much.
Well, thank you, Scott. I really appreciate it. And as I said to you offline, and your questions were amazing. And, obviously you know this world personally and professionally and in so many ways. And, I don't ever give false hope, but there is almost always hope. And don't give up. Find someone or someone's in the village that you connect with and can provide that support, because I am so blessed to live and work my passions. It makes every day worth getting up for. And find your passion, whatever it is, and go for it.
To learn more about today's guest, visit drohara.com. That's Dr. Dr. O'Hara.com. drohara.com. Thanks for listening to today's episode. If you're enjoying the show, please leave a positive rating or review, as doing so will help the show reach a broader audience. To follow me on Facebook, Instagram, Twitter, or MeWe, you can find me there as Better Health Guy. To support the show, please visit betterhealthguy.com/donate. To be added to my newsletter, please visit betterhealthguy.com/newsletters. This and other shows can be found on YouTube, Apple Podcasts, Google Podcasts, Stitcher, and Spotify.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.